Experience without theory is blind, but theory without experience is mere intellectual play. Our first speaker is Mr. Ghulam Mustafa, formerly a part of Shaukat Khanum Hospital. He's an American board-certified pharmacotherapy specialist. Currently, he's working as a pharmacist with expertise in oncology, hematology at Sheikh Shaukat Medical City, Abu Dhabi. He'll be explaining the role of clinical pharmacist in oncology clinics. He'll be joining us online.
Assalamu alaikum, everyone. My name is Ghulam Mustafa, working as a cancer care clinical pharmacist at SSMC Maya Clinic, Abu Dhabi. I have nothing to disclose, but I will use my in-house software to illustrate some chemotherapy regimens and my workflow. So today I will talk about clinical pharmacy services inside SSMC and in-house hematology, oncology, chemotherapy, CPO modules, oncology live tracking board around all our facilities, and chemotherapy CPO regimen review, resources, and references, anticoagulant and oral set clinic. So this is our oncology, hematology, BMT clinical pharmacy team. Under manager of pharmacy, we are working as one clinical pharmacist, 1, 2, and 3, team of 3 as hematology, oncology, and bone marrow transplant services. So currently we are with the adult hematology oncology services. So oncology clinic team workflow. In an oncology clinic, as a team, physician, nurses, infusion center pharmacy, clinical pharmacist, and case coordinator is a part of the team. So nurses will do the preclinical evaluation, and then patient go to the physicians, and then patient evaluation, and patient evaluation physician will activate the chemotherapy CPOE orders. And then clinical pharmacists review the protocols, and with all indicators, I will discuss you about the indicators next slides. And of course, then we are the part of the activation of the protocol as well for the subsequent chemo cycles and chemo days, sorry. For example, azacitidine, we are using from day 1 to day 7. Day 1 will be activated by physician, and then rest of the day by clinical pharmacists after nursing evaluation and lab evaluations. So after clinical pharmacy review, the order goes to infusion center pharmacy, and in the meantime, they are reviewing the chemotherapy orders and generating the labels and preparing and sending back to the nursing stations. So nurse will reevaluate the patients before the chemotherapy administrations, and the independent double check is going to be happen. The next is case coordinator. That is very important task of the team because insurance need approval for each patient, for each regimen. The next is our CPOE orders markers, regimen markers. For example, treatment plan definitions and intent of therapy, line of therapy, cycle numbers, day and length of therapy, cycles, days, and total number of cycles. So treatment plan definition as heme, onc, DARA, KD, and then of course the adjuvant, neoadjuvant, and palliative therapy. And then the length of therapy is, if you see here, cycle 1, cycle 2, cycle 3, 6, cycle 3 to 6, and cycle 7 to onward. And then if you see here, the additional information also is a part of the chemo CPOE regimens that include all these basic important factors. This is the hematology CPO power orders plan. If you see on your left, there is a power order in oncology. When we click on this power order, this window will open, and there is a whole plan here. If you see here, heme onc DARA KD protocol for multiple myeloma. that consist of cycle 1, 2, 3, 4, and so on. And if you see here, each chemotherapy cycles have a phases, subphases. So if you see here, lab and diagnostic, chemotherapy phase, and supportive therapy for day 1, day 8, and day 15, and then same for post-chemotherapy prescriptions, hypersensitivity reactions, and pharmacy review, where a clinical pharmacy put his review as an initiator of the plan of cycle, and then scheduling of the rest of the cycle is here. So scheduling. Now, on the right side, if you see here, we can here in this window, we can skip the cycles, or we can start or copy the cycle here, and it will reflect accordingly on the left window. So the next down window is to compare the cycles 1 with cycle 2, or cycle 2 to cycle 3. You can compare 2 cycle each time to review the doses. And this is the definition of the plan. Now the next slide is oncology CPO order review. And if you look into it, I selected from oncology, and that is Onco Breast Keynote 355, gemcitabine, carboplatin, pembrolizumab. And same, we have the phases here, chemotherapy, antihypertensive, post-chemotherapy, and same reflecting on the right side. This is the regimen. Sorry, this is the regimen references keynote. The next is a power order reflecting chemotherapy plans, as I explained you before, as a screenshot from my softwares. CPO orders. Here is the complete definition of this CPO order modules: power orders, medication list, and document plan. So lab and diagnostic, chemotherapy and supportive therapy under power orders, pharmacy review, hypersensitivity kit, and scheduling. And under medication list, chemo order list as a plan days, and medication list as a routine medication or other than chemo plan. The next is very important part of the CPO orders in our software. That is a documentation plan for clinical pharmacists, oncology pharmacy, and nurses 1, nurses 2, and physicians. So clinical pharmacists can review, and this is technically where we put our note, and it will reflect to physician, in infusion center pharmacy, and nurses, and the whole team who want to review it. So pharmacists, and these note can be saved into the power note as well automatically. So pharmacists can send back again for the physician for review if necessary, and the infusion center pharmacist can also send back, and physician also can hold or review the action plan. This is oncology review board. That is another brief information about the CPO order plan for each patient that include oncology summary, oncology flow sheet, timeline, febrile neutropenia, treatment calendar, and disease staging. So each stage is well equipped with the informations which can be used by the clinicians or physicians for the chemotherapy plan review with respect to labs, imaging, appointment, prescription history, and febrile neutropenia, antibiotic use. For example, here I'm here the febrile neutropenia. If I explain this one, this is give us the complete history for the febrile neutropenia treatment during the course, entire length of the chemotherapy plan. This is our oncology live tracking board. That is our daily practice where clinical pharmacists can review the patients. These are the patient bed number, name, MR number, attending physicians. And we are working as a SS infusion center, so it's reflecting to us all our patients. So see here, that's events reflecting all the events related to the 2-day plan for the patient from physician side, for the nursing, note, for the clinical pharmacist note, and for the laboratory note. So it will present by objects here that reflecting the particular task has to be performed by clinical pharmacists, nurses, or laboratory. So when we click here, it will open, pop up, and it will give us the informations what we have to do and for the further process. So this is a competency framework that is very important for as a clinical pharmacist, we have to review the CPOE order in these specific plans. For example, if we look for CPOE orders, so we have to look for these specific plans in it. Patient, of course, patient identification, regimen, which regimen he is going to be used, and then organ function labs, numbers, any numbers, patient weights, and all the stuff, calculation of the doses, BSA or AUC. So here, the organ function labs is very important as a clinical pharmacy point of view. You have to look for the labs and all the stuff here to verify the individual drugs with respect to the complete regimen plan. The next is toxicity sports. You have to look for it. Drug interaction, drug allergy, acute and delay nausea, vomiting, hypersensitivity reactions, and antimicrobial use, prophylaxis needed, antiviral, antifungal, denosumab, and bisphosphonate, and supportive therapy. And you have to look for tumor lysis and other common immunotherapy related toxicity. So order entry and CPO activation, order first activated by the physician, and then pharmacy, clinical pharmacists review it, and then it goes to the infusion center pharmacy who will verify, generate labels, and all the other stuff they completed to send the medications to the nursing stations. The next, these are the risk factor to be considered as a clinical pharmacist if you are working as a team in a infusion center. So high risk of errors if no accredited staff is involved, and if you go for it, not the other point is not following the established protocol. Perceptions that oral SAT is not as toxic as IV SAT. Any systemic anti-cancer, oral anti-cancer drugs therapy is not as much toxic as IV. So this is not true facts. So you have to look the oral systemic anti-cancer therapy in the same way as you are going for the systemic anti-cancer therapy, because now the novel drugs, the oral BTK inhibitors and others drugs are very important to look for their toxicities. So next is incomplete or eligible prescriptions, and then incorrect dosing or modification, incorrect labeling and dispensing, no proper trained spill kit management, and staff during transport. That is a very important factor as well during the team workflow. And then the patient not consults properly for the oral and supportive care, or how to manage the side effects. This type of cancer therapy we are looking for in a daily workflow. The chemotherapy, hormonal therapy, targeted therapy, immunotherapy, radiation therapy, and CAR T cell therapy or CAR cell therapy. So here, if you look here in the figures, I summarize some important drugs. If you see here, these are the new molecules who is under investigations and going to be marketed in the future. Going to be in the market in the future. So here, if you see here, aerobic glycosidase inhibitors, and then pro-apoptotic BH3 mimetic agent, and then PrEP inhibitors and VEGFR signaling inhibitors, and selective inflammatory anti-inflammatory drugs and telomerase inhibitors, amino-acting CTLA4 MAP inhibitors. Next, I select today 3 or 4 drugs for you for the drug-specific lab evaluations when you are sitting on a desk and looking for the patient profile. You have to look for some specific lab markers to verify the drugs and its appropriateness and dose adjustments. For example, for bevacizumab, you look for hypertensions, heart failures, blood pressure or echo. You have to urine protein and serum creatinine, anticoagulant he's taking or not, plan of surgery. You have to stop for 6 weeks or before surgery and after surgery. You have to continue after surgery, at least 6 weeks after surgery. And wound healing and complications, you have to look for it. These are some important adverse reactions and its management after bevacizumab. You can go for it, and in the references you can look for in detail. And then this is the next slide, the same adverse reactions, some other adverse reactions, and you can act accordingly to adjust the bevacizumab dose. Next, I select the panitumumab, EGFR inhibitor, wild type KRAS and RAS. So the most important point is for panitumumab is a box warning for dermatological toxicity. So in this point, the counseling point for the patients is prophylaxis topical emollient, corticosteroid, doxycycline topical or oral, or SPF 15 sunblocks. So you have to guide the patients to use it. Electrolyte depletions, magnesium and calciums, and monitoring. You have to look for the labs, and then same for ocular toxicity if there is any documentation or a visit with the ophthalmology clinic. And pulmonary toxicity, you have to look for X-ray, CT examinations, and then of course with all these things you have to look for RFTs, CBC, ocular and dermatological follow-up as needed, is in the future plan or previously has been done or complete by the patients. These are the adjustment of panitumumab in hepatic and pulmonary toxicity. If you see here, for the pulmonary toxicity, you have to interrupt the treatment plan if you see the worsening of the pulmonary toxicity. And then I select the third drug, ipilimumab. The dermatological toxicity is most important with the ipilimumab. Ocular toxicity, if you see here, amino-mediated blepharitis and episclerosis, iritis, orbital myositis. You can look for these things and in the physician note specifically. And pulmonary toxicity, you can see for imaging. And then, of course, you have to look for TSH, T4 free, ACTH, LFT, RFTs, and you have to look for dermatological follow-up as needed if there is in future or in a previous visit. These are again another reference for hepatic and renal dose adjustments for ipilimumab. And these are the toxicity of ipilimumab and its adjustment accordingly. For example, if I select here dermatological toxicity, mild to moderate, exfoliating dermatological conditions, you have to withhold ipilimumab. And as I mentioned you before, you have to use the emollient, topical corticosteroids, or topical antibiotics. So this one is you can look for it. Then other toxicity, if you see here, ipilimumab, for example, I go for GI toxicity, colitis, grade 2 and grade 3, 4, there is a different reference to be start on. So you have to look for if there is a grade 3, grade 4, diarrhea, severe diarrhea, you have to look for the permanently discontinue of the therapy. And then next, I select the oral BTK inhibitor, ibrutinib, and that is used for chronic graft versus host disease, refractory to steroids or general ruxolitinib therapy. Then there is a chronic lymphocytic leukemia, mantle cell lymphoma, marginal zone lymphoma, and Waldenstrom macroglobulinemia. This is a dose adjustment. For example, this is hepatic B-cell malignancy and chronic graft versus host disease. You have to look for it specifically at disease accordingly. Then the adverse effect, if you see here, the most common adverse effect with the ibrutinib is cardiac arrhythmia, grade 3 and grade 4, and you have to look for ECG monitoring. It's depend upon the institute. We are usually recommending early start with the weekly ECG monitoring and of course the others biomarkers for the heart failures. So we will move next now towards some references, access sources, resources, which can help us to look comfort and easy how we can quickly find the references to look for the most appropriate answers for our queries. For example, this is the first references, Lexicom and UpToDate. You are familiar about these two references, and these are the paid one. Then the next one is EMC. This is the European medical references that give us the complete references about each part of the drug-specific properties. For example, this is EMC is more commonly towards, if you see here, this is pharmaceutical properties of the drug is more explained comprehensively here. So if you see some, want to see specifically some pharmaceutical properties, you can access to EMC. And then of course, BNF, you are familiar. Drug references, Lancet oncology references, that is good for the renal and hepatic impairment, and it contains all the anti-cancer drug, oral or IV. Then of course, Google is our good companion and our quick references for everything, but you have to do in a appropriate way to access your references in a quick manner. For example, you have to type protocol name, space, NHS, space, and PDF. So you will go for this and you will get your references. And then is a St. Louis Cancer Center chemotherapy protocols that also give us the complete information of all the chemo protocols and their specific regimen algorithm. And I look for this site, especially is a very good information about the algorithm of the treatment care plan for each cancer treatment. This is another reference, and SSG, hematology specifically. You can go here and you can look for the references. BC cancer, you can look for the BC cancer reference in this way. Then is a EVIQ references. This is very good references, same like the NCCN template and BCC. But this is give us the complete information regarding protocol and its guideline, is pre and post therapy and day of therapy. It's reflect everything here in a detailed form. And then this is a most familiar reference, NCCN reference. You are familiar with these references, and this is a paid reference as well. And we can source out the template for our sportive therapy. Now there is ESCO, ESMO, and ESMO, and ASH, American Society of Hematology, is another reference source for us. There is NCCN guidelines for sportive cares. So sportive cares, we can look for NCCN in a complete comprehensive form. Nowadays, we are doing for looking for this immunotherapy related toxicity management in our SSMC, and we are preparing an algorithm and workflow between ER, ward, inpatient ward, infusion center pharmacy, and the IV pharmacy. So these are the online training. Each pharmacist has to be look for it. And BCOP, for example, the first one is a BCOP certification. This is American certifications. Then there's a BC cancer training. These are courses are free, and this will give you a very good information, and it will increase your capacity to learn about the chemotherapy management. So next is BOPA, British Oncology Pharmacy Association. This is also a very good comprehensive source to learn. HOPA, My Clinic, EBMT, ISO. So next is this is our clinic pathway we are doing here in SSMC, and specifically clinical pharmacist is running the anticoagulant clinic with as a team with the physician and the nursing team, of course. So this is the pathway we create for the clinic, regular pathway. For example, patient on these things admitted to a pharmacy, IP SSMC ward, discharge, then discharge, consultant need INR monitoring, they can refer the patient to the clinic, and clinical pharmacists and nursing team will take care of it. And I will explain you in the next slide. So nursing team will do his lab work, and on clinic day he will do the POCT, INR, standard clinic patient assessment, and then the lab and INR previously, if available, or on the day of the patient visit, nurse will do it. The next will be the clinical pharmacist role started here, and clinical pharmacists will look for the INR and other drug interactions and adjust the dose of anticoagulant as required to achieve the target INR with specific disease conditions. So next is the IM consultant role with the clinical pharmacist. Meaning clinical pharmacist can consult with the IM consultant on call, and he is aware about the anticoagulant clinic is running today, and he will answer the clinical pharmacist query if he has any query regarding specific patients. And clinical pharmacists document everything as a power note, and it will reflect for co-sign to IM consultant, and he will review and he will co-sign the orders. Next is the same plan we are running for oral side clinic. So this is our future plan, and this is my last slide now, and we will go for this clinic future plan for oral side clinic. The target patients are different, likely oncology, hematology, and post-BMT and GVHD patients. And again, there is a challenging staffing, nurses and clinical pharmacists and so on. And this is my last slide now, efficacy versus toxicity. Maintaining the balance to look like a sky high when we are looking for toxicity or cancer treatment efficacy. Thank you very much. Any question, you can email me or ask me on the day of presentations. I will be available virtually. Thank you very much.
Well explained. With this, I'd like to continue on to our next speaker, Mr. Sajadullah, Senior Clinical Pharmacy, Shaukat Khanum, Peshawar. He'll be sharing his insight on how to strengthen medication safety in collaboration with American Society of Health System Pharmacists in Khyber Pakhtunkhwa, Pakistan.
Yeah, thank you, and assalamu alaikum. Thanks to you for all for being here. Today's topic of presentation is strengthening of medication safety in collaboration with American Society of health system pharmacist and KPK. This is the first ever time that we are introducing SHP residency program in KPK. We all know that medication is nowadays the most frequently used modalities throughout the world to treat illnesses. However, improper medication may have a catastrophic effect on the patient illnesses, may have increased burden of cost, treatment illnesses, and length of hospital stay. So the objective of topics today, we will discuss the medication safety challenges, medication safety in transition of care. They're very important. SHP residency in KPK, training of resident in preventing medication errors, summary, and the future perspective. Same as reported, the Institute of Medicine in the US reported that 7,000 deaths occur yearly due to medication error. And these are all preventable errors. And the cost of these medication errors about $3.5 billion. So medication error accounts about 1 out of 131 inpatients and 1 out of 184 outpatient deaths. So continuity of care is a longitudinal process that ensure proper and safe medications. BAT reported 42% adverse events that are preventable and caused by the administration, about 34%, transcription error about 6%, and dispensing error about 4%. And for these errors to reduce the intensity of error and to have medication safely used, the ISMP suggested to reduce reliance on your memory, to use a computerized order entry system, and to limit the drug formulary in your formulary, and also use the dosage strength in your formulary. So unlike a developed country where the medications is under control in controlled regulations, however, in Pakistan, we are in developing countries, we didn't have such kind of challenges. So we are facing such kind of challenges. Most of medication that any kind of medication you can get it in Pakistan easily from any pharmacy. So many alarming situations from these self-medication occur due to like increased resistance of antimicrobial therapy, withdrawal symptoms, failure of therapy. All these are effect at the end we are facing. So according to WHO, 10 million people die by the year of 2050 in the absence of effective control measure against drug resistance. In 2019, the government of Pakistan has taken an initiative that has shut down about 20,000 pharmacies in Punjab, and the same we are expecting in KPK and whole Pakistan. So the most devastating situation, like about 5.5 million people, including women and children, die each year due to medication error. Self-medication and self-viral limiting infection is one of the major, I think, cause of self-medication in population of Pakistan. However, we are coming across to some pandemics like COVID situation. Many people have started self-medication due to ease of access and to avoid contacting in the population and hospitals. And these self-medication has increased the illness of burden, the cost, and the length of hospital stay, morbidity, and ultimately mortality rate. Same is the case with the dengue fever. In dengue fever, most in home, we often use like aspirin, diclofenac, non-steroidal anti-inflammatory drugs, which could result in bleeding and ultimately cause mortality rates in dengue fever, but we are lacking such kind of data. So this is one of the good examples that drugs that end all your dreams. So whenever you are dreaming, so avoid self-medication, your dream will be fulfilled. The best example for medication safety has taken initiative by the WHO, the tool that engage the patient to empower and house in his own therapy to save the medication use. This tool engage the patient and the caregiver as well. Also, one of the important tool, as I think, for the pharmacist to engage the patient during counseling before starting any therapy or taking any therapy, adding a medication, review any medication or stopping any medication. So the patient and the counselor, either the physician or the pharmacist, should be able to do it as such. Medication transitions is one of the big issue. However, in Pakistan, we are also lacking such kind of data and during medication error. So in continuity of care, medication error during transition of care between one healthcare provider to another is one of the big issue, as it is more prevalent in the discharge and during hospital stay, as seen 25 to 80% of patients having at least one transition medical discrepancies during transition of error. Also, it seems during hospital admissions, about 97% adult patients and 72% of pediatric patients having at least one transition medical discrepancies at the transition of error. For this purpose, we are continuously educating our staff to do a reconciliation at the time of discharge, at the time of hospital admissions, and at every OPD clinic visits. So the man in 2017, WHO emphasized that the main leading cause in transition of error was the miscommunications. They reported if communication is improved, about 97% of medication error are improved in transition of error. Another study was, I was studying in a Ukraine-based, about 20 study that they have pulled out 559 out of 1,000 patients have a medical discrepancies and transition of error. And this is one of the alarming situation, and this is a global issue. So in KPK is the province of Pakistan located in the northwest frontier eastern region, and it comprises about 35 million of populations, constituting about 11.9% of the population of Pakistan. KPK has a mesmerizing landscape, hospitality, and a very good cultures, but we are lacking in some health issues. Initially, during the last 5-7 years, the KPK government has started take initiative to bring health reforms, which they include to increase the staff and to equal the health care related issues for the poor and for the wealthier patients. So they remove the inequalities in health and enable each and everyone to get the same health at the same cost. But we have, despite health reforms, we have many challenges. We are lacking of certain in the field of pharmacy, specialized clinical pharmacist. Medication storage and dispensing are just limited to by the pharmacist. They do not do anything other than the medication storage and dispensing. Antibiotic resistance and multiple drug resistance strains are common, and there is no educational sessions in KPK. We are expecting, we are the one in Shaukat Khanum, they are doing the antibiotic stewardship, having antibiotic stewardship and extensive rounds and presenting data every quarter. In KPK, we have 7 large hospitals that are lacking any internationally recognized residency program and any internationally accredited certifications. And thanks God to Allah that we, Shaukat Khanum, the only one JCI accredited in KPK. Same is the case with the skilled human resource. Like we have nothing in KPK, the specialized like in clinical pharmacy especially. Shaukat Khanum will be the first to start residency and produce the clinical pharmacist in every specialty. So beginning makes the condition perfect. Always beginning is hard to, but whenever it started, it created an opportunity for the new one. The new year began for, especially for the KP pharmacist, to avail the opportunity of SHP residency. We have started SHP residency, PGY1 residency. So the main purpose of SHP residency is to orient the pharmacist to the recent knowledges and skills that they have developed in the patient-centered care to avoid any drug harms and drug error during the patient's care. So this is the Shaukat Khanum Hospital, Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, the only non-US based hospital is accredited, and the Shaukat Khanum Memorial Cancer Hospital is in the candidate list, the Peshawar. So there are certain requirements for the SHP residency to qualify. For a resident must have a Form D degree or have 4-year collegiate program plus 1 year pharmacy practice experience. The resident must have a license where the program is conducted. So there are some requirements that the resident will have to pass the pre-screening test and pre-screening interview. After then the final selection will be made. So the learning experience that is included for the residency program, the orientation is made. So the orientation purpose of orientation, that at the end of orientation, the resident can work as a pharmacist. He will be taught about the workflow of pharmacy, the policies, and the knowledge and the skills that need to be developed during his residencies. The competencies area include the 6 competencies area, and other are the elective areas. So formative elevations are the ongoing elevation that the preceptors are giving the talks to the resident, and they are doing at that time. While the summative elevation are done at the end of each rotations, the learning experience by evaluation the resident do by his own, by own himself, and the preceptor evaluation also is a mutual evaluation by the preceptor and the resident. Medication safety, one of the most important picture, I think so, in this slide for the resident that they can see from this slide very much. So appropriate prescribing and effectiveness of medication is started from the appropriate prescribing by risk benefit ratios. After that, the resident will have an extensive review of the medication by ensuring the appropriateness review, the right drug dose frequency, if there is any therapeutic duplications, if there is any drug interaction, drug food interaction, if the drug is variation from any hospital criteria, or the drug is according to the physiological weight base, lab base. So this is one of the most important for a resident. Dispensing and preparations is also to ensure the 5 rights before dispensing, and to ensure independent double check at the time of dispensing. Communication is one of the most important thing to communicate with the healthcare provider and with the patients. So always use your heart whenever you communicate. You have to hear, you have to empathy to show your empathy. You have to listen. You have to timely respond to the patients. Medication reconciliation, we often educating our staff to do a medication reconciliation during admission, discharge, and the time of readmissions. So the SHP resident will have an extensive clinical round rotation and multidisciplinary approach, as the resident can gain the skills and knowledge to avoid any kind of medical discrepancies whenever he doing any round or reviewing any patient charts. He will be able to monitor individual patient therapy. He will be able to, resident will be able to analyze the gaps that are in between the prescriptions, to remove that gaps and make the prescription safe for the patients. Patient-centered care approach and care plan, resident will be able to make their own care plan for each patients that are able to for that plan. He will have to make an action plan and follow-up plan. Medication reconciliation, as I told, is one of the most important during the transition of care and at the time of discharge and readmissions. ADR monitoring and management is also, resident will be able to monitor the ADR and to manage the ADR. Later on, I will show the slide of impact of residency He will be actively involved in peer review and journal club presentation is one of the requirement of residency, and also research a longitudinal experience that will be ongoing throughout the year. The care plan format that the resident can make by himself to make an action plan for the drugs and for the disease that the patient is suitable for that plan, and the follow-up, the monitoring that they will have to include in this care plan. So you could see the comparison of the trend SHP resident on medication safety. This is the 4-month data that I have extracted in Peshawar. The recruitment of SHP, before the recruitment of SHP and after the recruitment of SHP resident. We can see the patient care plan that has been increased from 180 to almost 250. And this is one of the good signs for our hospital quality indicator, key pharmaceutical indicator as well. As seen in the adverse drug reactions, the reporting has been increased from 25 to 42%. There is a massive increase in interventions, a twofold increase has been seen from almost 2,000 to about 5,000 interventions in the last 4 months. So at the end of residency, a resident will be able to recognize the harm that could lead to medication error. He will build the safety actions for that harm and remove all that medication that could harm the patient. The high alert medication, high process that needs special attention and protocol, the resident will have to go all these processes during his residency. Evaluate medication appropriateness. He will be able, or resident will be able to evaluate appropriately medications. Medication management, he will be able to identify the gap and analyze where the problem is, and he will be able to remove all that problem from medication therapy management. Improve medication adherence by proper counseling through her that, as I told, that to hear, to empathy, apologize, respond, and to thanks to the healthcare and to the patients as well. So in summary, as I told, medication use is not a risk-free activity. Whenever using a medication, always think about the patient, and the patient safety is our first concern. To avoid any medication error, we need to optimize the therapy first and remove that error at the time. So that will ultimately lead to reduce the cost on the health and reduce the illness and length of hospital stay and the patients. So she is our first resident in KPK with the preceptor. The future perspective, as soon as possible, our PGY1 residency is accredited. We will soon, inshallah, start a PGY2 residency, inshallah, to help assist the public and private hospital who wish to start residency, and to also offer training to a pharmacist in a specialized area in the private and public sector of KPK as well. Thank you.
So before I call upon the next speaker, I'd like to remind for those who came late that we have a little quiz at the end. So you might want to pay attention to the presentations. The growth and development of people is the highest calling of leadership. That being said, we'll move on to our next speaker, Mr. Ihsan Elahi, Assistant Manager, Clinical Pharmacy. With over 8 years of profound experience in adult oncology and hematology, Mr. Ihsan is an unrivaled strength of our pharmacy team at Shaukat Khanum Hospital. He'll be presenting the role of pharmacist and current practices in oncology pharmacy in Pakistan.
Assalamu alaikum. Thank you very much. So before starting the topic, So before starting the topic, I would like to say that I have no potential or financial conflict of interest with any of the slides or the material to be shared during the session. In this session, we'll look into about a few statistics stating about the cancer burden of Pakistan, how many patients of cancer have been diagnosed in different areas and in Pakistan. Then we will discuss about the role of international organizations, what they recommend or what they state about the role of oncology pharmacy team, and about the scope of hematology and oncology pharmacy practice. And then we will discuss about what kind of services oncology pharmacy at SKMT is providing and how the clinical oncology pharmacist is ensuring the care of the cancer patients around the clock. So let's start with certain statistics. This is the data shared by Punjab Cancer Registry, and according to which from Jan 2021 to December 2021, a total of 6,507 patients were diagnosed with cancer, out of which 3,682 were adult female, whereas 2,322 were adult males, and 502 were from pediatric population. And this data is representing the population of Lahore. If we go into the detail of this data, we came to know that around 10 most frequently reported cancer of all age groups and all sexes, which were identified in this population, the breast cancer was on the top and comprising of around 1,774 patient population, whereas the cancer of the airways was on the bottom with 157 cases diagnosed in the last year. GloboCan, the Global Cancer Observatory, it provides the data of cancer incidence, mortality of each country around the world. According to this, the data of the 2020, it states that with a population of 0.22 billion of Pakistan, total number of new cases identified were around 1,78,000, and the total number of deaths were recorded as 1,17,000 of the patients. The detail of the new cases is like that around 88,000 patients were diagnosed with males of all ages and 90,000 were of females of all ages. Let's have a look at what are the resources and how many institutes or how many centers are there in Pakistan, which are currently providing the cancer services to this patient population of 1,78,000. So we came to know that as per the Wikipedia, there could be some other resources, there could be some other missing institutes as well. But there are around 38 dedicated cancer institutes throughout Pakistan, which are located in different localities. And they have been recognized to provide the patient care, and they have been affiliated, or they have been granted the license to provide the oncology services to the suffering, to cure the suffering of the cancer patients. These centers are located in different areas of and different provinces of Pakistan. You can see that 10 have been recognized in Punjab. There are 16 institutes which have been provided license with oncology services. There's only one institute which is trying to cater the suffering of cancer patients in Balochistan. There are 3 institutes which are functional in Islamabad Capital Territory. There are 6 in Peshawar, 6 in the KPK, Khyber Pakhtunkhwa province of Pakistan. There's only one cancer institute which is responsible to provide the patient care in Kashmir, and specifically in Azad Kashmir. And there is only one institute which is present in Gilgit-Baltistan and responsible for cancer care. Around half of the cancer institute which have been recognized or granted to provide the cancer care, there are 5 institutes of Punjab are located in Lahore. Before going to the role of pharmacy or the oncology services being provided to the patients in Pakistan, I would just like to highlight what international societies provide, what kind of recommendations or what kind of guidelines they provide, which governs or which guide to develop the role of oncology pharmacy team. So first, I would like to discuss about the International Society of Oncology Pharmacy Practice, the ISOP. The main focus of the ISOP is to recognize the oncology pharmacy practice within an institute and ultimately within the region. Currently, worldwide, the oncology pharmacy services have not been formally recognized. So the ISOP states that the institute must take an advantage. It must take an advantage of the local or the regional policies, which will definitely direct about the role of oncology pharmacy team, majorly the pharmacists and the technicians. So it states that there must be a recognition and support of the pharmacy services specifically located or working in an oncology center. So first thing is the oncology pharmacy practice must be recognized as a pharmacy specialty, just like other pharmacy specialties have been recognized or are being recognized in different institutes. The ISOP states that the team member on the oncology pharmacy team comprising of pharmacists and technicians must contribute to the direct patient care. They must be involved in multidisciplinary healthcare teams. The pharmacist must perform the appropriateness review. The pharmacist must review the whole medication. They must look for the chemotherapy protocol, the chemotherapy drugs, about the counseling, the education, each and every perspective of the patient care should be provided by the oncology pharmacy team. ISOP states that there should be a practice management. This is about, you can say, the management of the pharmacy, which is directly involved in designing and implementing the standard operating procedures, the policies, and this is actually responsible for the human resource. This is actually responsible for planning the further educational processes, programs for the healthcare team members like pharmacists and technicians, and to have some certain accreditations for the team members. So education and training is the main core of this oncology pharmacy team. There must be a program where the team member should go through and to improve their skills, their expertise in the field of oncology, and they must participate in any sort of investigational drug trial and must publish what kind of practices they are doing and what kind of practices they are looking forward in the future in oncology. ISO further states that the oncology pharmacy team should be fully incorporated in multidisciplinary healthcare teams. There should be a program to continually educate oncology pharmacy team members, and the legislation and the government bodies must play their role in certifying different programs which are responsible to improve the skills and knowledge of this pharmacy team. Moving towards the next, as stated earlier, the Hematology Oncology Pharmacy Association. In 2013, the Hematology Oncology Pharmacy Association came up with a document which summarized the scope of hematology oncology pharmacy practice. Later on, with the evolving role of oncology pharmacists, in 2019, the Hematology Oncology Pharmacy Association came up with new advanced roles of oncology pharmacists, which have been highlighted in this slide. And according to the HOPA, the Hematology Oncology pharmacist's role has been advanced from medication dispensing to the direct patient care. So if we categorize different roles of oncology pharmacists, the first come is the inpatient clinical oncology pharmacist. This pharmacist is majorly involved in the pharmacotherapy of all those patients who are admitted within the ward. This pharmacist is directly integrated with the primary healthcare team who is responsible in providing the patient care in the ward. This pharmacist is responsible in collaborating the nurses and other healthcare professionals in ensuring the safe and effective medication, the safe and effective chemotherapy drugs, the safe and effective chemotherapy drugs and supportive medication to all those patients who are admitted to the hospitals. The next is the ambulatory clinical oncology pharmacist. The role of this pharmacist majorly lies within the clinic. Within the clinic, this pharmacist assists the clinicians in deciding different chemotherapy drugs, chemotherapy protocols for different patients. This pharmacist within the clinic reviews the lab values, the physical parameter, the physiological parameters of the patient, any drug-drug interaction, drug-food interaction, or any kind of drug duplication before starting or initiating the chemotherapy order. This ambulatory clinical pharmacist, in fact, follows the patient once they get their chemotherapy in the outpatient department, and he may discuss with any kind of adverse drug reaction being faced by the patient after the administration of chemotherapy. Next is the infusion center or decentralized oncology pharmacist. This is basically what the aseptic teams do. So the aseptic pharmacist is basically the infusion center, you can say the decentralized oncology pharmacist. His main activity is to review all the patients who are in queue to receive their infusion therapy. This pharmacist will review the patients through medical charts, will discuss, will review the plans, and will go through the notes and the plans of the physician, the primary care team, and then will generate the labels of the patients. And this pharmacist will ensure the safe and effective preparation. And after that, after the preparation, this pharmacist will review the whole preparation process and will finally dispatch the medication to the chemo bay or any other outpatient department where the patient is getting the chemo. Next is the specialty pharmacy oncology pharmacist. The main role lies with the oral chemotherapy. This pharmacist discusses about the availability or the plan with the technicians that how this oral therapy should be discussed. This pharmacist follows the whole oral chemotherapy, dispense to the patient, discusses with the patient through teleclinic or telemedicine that if the patient is experiencing any kind of adverse events. And this pharmacist is directly involved with the oral chemotherapy is being prescribed through insurance process. And this pharmacist sometimes liaises with the ambulatory clinical pharmacist and inpatient clinical oncology pharmacist whenever this patient is being admitted for any sort of supportive medication. The practice management oncology pharmacist is basically the part which the oncology pharmacy management is involved. These people are involved in designing the standard operating procedures, the policies, they are looking for the human resources, they are working for the budgets, they are working for the drug approvals. They are directly involved they're directly involved in discussions which take place with the higher management to get drug in, out, formulary, non-formulary, and all the stuff like that. Investigation drug services basically coordinates between the investigating drug, between the nurses and the other healthcare professionals where the investigational drug is being used. So according to the HOPA, the role of oncology pharmacists has been changed, and it is not just limited to the dispensing of medication, but it has been advanced to the direct patient care. So when we look at the role of pharmacy, and when we look at the services, when we look at the facilities provided to the patients in the oncology centers, that is very, you can say, very unlucky for the patients, because in most of the oncology centers, which I discussed earlier, they lack the basic infrastructure facilities, and there is no dedicated oncology pharmacy service in their organizations. These pharmacies are basically working as a storage houses to provide the medication to the inpatients. There is no patient counseling. There is no oral anti-cancer administration counseling or no education to the patient. And there is very poor control of hazardous drugs and very poor management of the inventory of the hazardous drug. But this is not the thing that we must stop. There are a few organizations which are working in collaboration with the international standards, and definitely there comes the name of the SKMT, the Shaukat Khanum Memorial Trust, which is the state-of-the-art hospital, and the pharmacy department is state-of-the-art, working day and night to provide the safe and effective pharmaceutical care to the patient. It is the only second non-US based institute which is ASHP accredited, and the Lahore site is accredited with the ASHP. Peshawar is gonna be accredited in the future, inshallah. So if we look at the staffing, we have 40 pharmacy technicians in the SKMT, and from the pharmacy team, there are 3 ASHP resident pharmacists. 2 are in Lahore side, 1 is in Peshawar, and one will be added in the Peshawar as well. There are around 55 different pharmacists from the management till the pharmacists who are providing patient care. The journey of the SKM pharmacy just started when the SKMT was inaugurated. So with the passage of time, the improvement took place. And the main improvement was the development of a computerized physician order entry, which is the state-of-the-art hospital information system. It's very user-friendly, it is password protected, and it can be integrated even with the Android or iOS iPhone operating systems as well. And you can access this hospital information system from your home, from your cell phone. Later on, this process and this journey goes on, and it led to the development of outpatient department dispensing chemotherapy module. And after the successful implementation of outpatient department chemotherapy module, the inpatient department module was designed. And after that, a new strategy for the improvement of stacking to avoid the dispensing error was adopted, and it was successfully implemented. So this is the outpatient department chemotherapy modules, where the pharmacist, the infusion center pharmacist or the aseptic pharmacist works. He reviews all the patient medications in the unverified queue. And once the patient is verified by the pharmacist, the patient is ready to be administered for the chemotherapy. Later on, the inpatient department module was designed. There's a list of patients who are being admitted to the hospital, and the plan of whole chemotherapy is clearly visible to the patient, to the pharmacist, and he can easily manage or review every kind of lab values, physical parameter, physiological parameters before proceeding the chemotherapy. And this is the example of stacking plan we have in our pharmacy. And you can see the different colors or different arrows. These different colors are basically representing the type of the drug, rather it's high alert, non-high alert, or it's a cream, it's an injectable, it's a tablet form. So these are color legends, which directs you to the certain dosage form. And the drug name, the generic name, is all by the standards as advised by the International Society of ISMP. So if we talk about the services of oncology pharmacy, the oncology pharmacy at SKMT is providing 5 major services. The first one is the ambulatory oncology pharmacist, directly involved in providing the patient care to the patient, directly involved in the care of those patients who are prescribed medications from the clinics. Aseptic IV compounding pharmacy, currently 2 units are working. One is attached with the ambulatory services, one is attached with the IPD inpatient department, and there are the state-of-the-art aseptic compounding areas working with HVAC and additional other international standards, just like USP standards 800. Then is the oncology clinical pharmacist. We have dedicated oncology clinical pharmacist who is providing services, who reviews the chart of the patient who are admitted. The inpatient pharmacy services, it's a satellite pharmacy, and it is involved in dispensing of the medication to all the patients who are admitted. The oncology pharmacy in quality and patient safety is basically the task of the management, which is reviewing all the process of dispensing the medication, minimizing the medication error, and improving the safe pharmacy practices. So let's now talk about the role of clinical pharmacists. On the daily basis, the clinical oncology pharmacist is involved in the clinical ward rounding with other healthcare professionals. He is involved in comprehensive medication review, therapy management. He performs he reviews the patient and designs the therapeutic plan, which he finalizes in the form of patient care plan. He is involved in chemotherapy protocol designing and implementation, integration to the HIS. He is involved in chemotherapy protocol review and verification, which are prescribed to the different patients. He is involved in adverse drug reaction reporting, drug utilization reviews, and medication use evaluations. So this is the breakup of interventions done by clinical oncology pharmacists from Jan to October 2022. A total of 747 interventions were made, out of which 290 were related purely with the chemotherapy protocols. And this is only, this 290 is actually presenting the number of a chemotherapy protocol, not of single drug. That means ABVD means 1. It's not the 4 drugs. So if we consider ABVD as the 4, this would definitely multiply by 4. And the 457 were the other interventions which were done by oncology pharmacists. This is the chemotherapy protocol designing module. The oncology pharmacists work on it. All the protocols before integration and before administering to the patients are designed on this form, where you can see the protocol code, the name, description, the number of cycle, days, gap, any comment. And all these protocols, definitions, and implementations are guided by the principles of international organizations, just like NCCN, just like BC Cancer, as Sir Ghulam Mustafa already explained. In addition to it, after that implementation, this chemotherapy protocol looks like this. So you can see the chemotherapy, the pre and post chemotherapy drugs with dose, unit, schedule, frequency, duration of therapy. The oncology clinical pharmacist is directly involved in the blood and marrow transplant committee. He is involved in the clinic where he discusses and assists the physician, assists the clinician in designing the chemotherapy for the patient. He's involved in clinical trial, he's involved in policy making and implementation, different educational activities done by oncology clinical pharmacists. The research is the part of which, just like you can see that the oncology clinical pharmacist is working on research, not only related to the policy issues, but also related to the practice issue. And recently we have done research and we analyzed the data that since the development of online chemotherapy module, there were certain medications which were getting duplicated with the current medications. So in order to avoid the duplication of those medications, we designed first duplication review and then implemented in HIS. So all those drugs which were getting duplicated, you can see that the color of filgrastim is changed. This was an indicator for the pharmacist. And then a queue in the dashboard is created. The pharmacists just go and acknowledge that. And we came to know that after the successful implementation of this medication duplication alert, the order duplication reduced by 61.53%, and the time by the pharmacist to intervene, the time required by the pharmacist to intervene was reduced by 81.85%. So this was huge when we analyzed the data. All right, the journey is not stopped here. The things are going on, and the future goals of this oncology pharmacy is to get the IPPR Year 1 Peshawar, IPPR Year 2 Lahore. We are moving towards the COPIS certification. And in addition to that, the barcode enabled dispensing is our new goal. Smart pump integration with chemotherapy doses, rates is being planned. And we are trying to incorporate the CST closed system drug transfer device. Thank you very much.
Thank you, Mr. Ehsan, for that elaborate presentation. Education is not the learning of facts, but the training of the mind to think. I would like to call upon Mr. Shoaib Shamas, manager of Shaukat Khanum Pharmacy, Lahore. He's an American board-certified sterile compounding pharmacist, a man of many talents. Mr. Shamas will be presenting contemporary role of the pharmacist in developing state-of-the-art clean room in oncology care settings.
Assalamu alaikum everyone. मैं नजर आ रहा हूँ उधर कि नहीं? Presentation नजर आ रही है कि नहीं? आ रही है. Good. So today we are going to discuss the contemporary role of a pharmacist in developing state-of-the-art clean room in oncology care setting. I have nothing to disclose. So moving forward to the case of 3-year-old admitted patient for the burn treatment. During the treatment, wrong injection was given to the little girl, and she died on the spot. This is one of the case of the Pakistani hospital that on the spot, because of the wrong dispensation of the medicine and failure of independent double check at the level of administration, and because of that, she died. Case 2, 9-year-old kid admitted in the hospital for the treatment of the diarrhea. She received high dose of concentrated electrolyte without being further diluted. A minute later, her lips turned blue, breathing difficulty started, shifted to ICU, CPR done, revived back, put on ventilator, and for the further management. CT shows brain injury and patient was paralyzed. Later, after 2 weeks, she also died because of the concentrated electrolyte administration to the patient. And because of that, if as per the ISMP states that every time the concentrated electrolyte must be diluted before the administration. So are these events preventable by the pharmacy or pharmacy team? Yes or no? Yes. Yes. Awaaz nahi aayi. Yes. Good. So further, healthcare worker are also exposed to hazardous drug while handling, receiving, preparing, transportation, administration, handling body fluids, and the disposal of that products. So there is currently there is no specific defined limits of hazardous drug exposure, and if the weak control of healthcare protection lead to the hazardous drug exposure of that event. So in Pakistan, we don't have the dedicated requirement defined in our law for IV drug preparations. Yes, we have the law for the oral dispensation, but we didn't find any IV related product that you have the dedicated room for the preparation of the sterile products or like that. However, international bodies define comprehensive requirement and its legal implementation, including in the JCI, USP, NIOSH, OSHA, ISMP. They define the role of the pharmacist in the sterile compounding area for the dispensation of the medicine. So moving forward, what are the benefits of the clean room? Based on the reference standard, development of the dedicated clean room is to provide a ready to administer form of the drug. Then involvement of the multiple safety checks to avoid errors, and the safety of the healthcare worker with the minimal exposure. So what we expect that we have the clean room dedicated with the full equipment are also available, but the reality is something different. So this is one of the picture of the hospital where the chemotherapy is going to be administered to the patient. As you see, the patient is lying on the bed and the syringes and the needles are open. And these are the hazardous drugs, these are cytotoxic drugs that are going to administer to the patient, as it will lead to the exposure of the patient as well as the healthcare worker. So further objectives of this presentation moving forward, what is the definition of the clean room? Clean room in which the concentration of airborne particles is controlled and constructed in such a way that the generation of the introduction, generation and retention of the particle inside the clean room in which the relevant parameters are controlled. That is the temperature, humidity, pressure. So this is the conceptual layout of a sterile area pharmacy with the sporting zones, that is anteroom and the buffer room, and the ISO classified area. We call it as a hood, the biological safety cabinet, where the medication are going to be prepared for the dispensation. And this room is dedicated with the controlled temperature, humidity, and the pressure ranges. And further, if we move forward, what are the minimum requirement to design the area? That the lights, for example, the lights should be concealed. And even the USP states that how much the intensity of the light should be there for the preparation of the drugs, like lux of 1000 or 1500 should be there for the preparation of the drugs. And the walls, either in the epoxy or the antibacterial paneling, floor, vinyl or epoxy coated. And further, ISO classified the air classification into ISO ISO class 7, 8, and ISO class 5. And the door should be handle free. Noise level should be 75 to 80 decibels. And this is the detailed document of any development of the process, that the bill of quantities, starting from the preparation, design, pre-construction, construction, commissioning, handover, and the follow-up the processes, which include the HVAC requirement and equipment details, pricing of each individual item, commissioning detail, and the event timeline with that. So this is the most important thing, the biological safety cabinet. What type of hood or the biological safety cabinet is required for the preparation of the hazardous drug? So these are the multiple type available, like a type A1, A2, B1, B2. So this the recommendation is a type 2, B2, that is 100% exhaust with the negative pressure exit to the outside the area. Further movement to that, there is a personal protective equipment required for the preparation of the hazardous drug, that include the gown, that is a gown, cap, mask, shoe cover, beard cover, gloves, and the goggles. So keeping in view that the gloves should be standard oncology gloves. That is a pore-free glove. The standard is ASTM D6978. That is a pore-free glove for that purpose. Gown should not be permeable to any liquid to avoid the safety of the healthcare worker. And same is for the cleaning agent and for the further surgical supplies as well. So for the workstation should be recommended that workstation should be of stainless steel, easy to clean, long life, and the further grading, that is a very important thing. While requesting these stainless steel, usually recommendation is for the 304 grade that is more commonly used, and the 316 is the chemical resistance grade. So for that, you have stainless steel cabinet, trolleys, computer, trays, and the transportation should be made of the stainless steel. Further requirement, you have to install the pressure gauges for the pressure monitoring, pass-through window for the monitoring of the pressure differential and ISO classified zones, intercom for the communication system, and the weighing machine and the particle counter for ISO classification. Further to that, counter heighted chairs, that is specific 2.5 foot or 30 inches for the counter height, visual inspection counter for the particle counts, and the mirror for the proper wearing of the PPEs, flammable safety cabinet for the flammable items and the drugs. Hands-free sink should be there to avoid contamination, and the eye wash station for in case of spill into the eye. Further, computer usually suggested that the 3-in-1 system, that is a comprehensive one system that have all the equipment in that. Further, the printer, barcode scanner, or the QR code scanner, and the refrigerators. For that, USP attender recommend that there should not be a pass-through refrigerator available in that area. And further, there's a thermal printer that is available for the area to be designed. Then we have the Baxter repeater pump for the bulk or standardized preparations, and the tablet counting machine, automatic dispensing devices for the preparation of the TPN as well. Then we have the dedicated, we need to define a dedicated space for the hazardous drug, that either into the neutral pressure or in the negative pressure. And specific storage stacking techniques, receiving checklists, dedicated bins, commercial grade racks for the storage of the hazardous drugs. Then we have the specialized chemo transportation bag, amber color bag for the sensitive drugs, specialized transportation bins to avoid spillage, water degradable plastic sea-level bags. Then we need to define a standard operating procedure for that as well, for the role and responsibility of the staff working in that clean room, and must be have operational manuals to handle the biological safety cabinet and other respective equipments. Then we have to define specific waste disposal guidelines with a dedicated segregated bins, area cleaning frequency, and the training of the staff who are involved in the cleaning processes. Further, classification of the hazardous drug, then the storage of bulk storage of the hazardous drug, sterile area storage, and the multi-dose drug storage, and the final product storage at the nursing locations. Then we have to define the GHS coding, global harmonized system coding for the hazardous drug, and the material safety data sheet for each product that is going to prepare in your area. Staff is involved with evidence-based training. As you see, this is a chemo check kit that is used by the staff during the preparation and the training purposes to see either there is a spillage during the whole process from the preparation till the administration of the drug. And then further chemo spillage competency to avoid further hazardous exposure. And this is the most important thing, to follow up monitoring parameters for the product safety. You need to go for the microbial testing, environmental testing, air changes, pressure differential, smoke studies, HEPA filter testing, ISO classifications. Further equipment should be calibrated for that area. Then the personnel monitoring, and that include the medical surveillance program of the staff who are involved in the hazardous preparation. Then the fingertip testing and media field testing, and the reporting should be communicable to all stakeholders of the concerned department. Additional technologies that include the camera-assisted medication verification, robotic biological safety cabinets, closed system transfer devices to avoid hazardous drug exposure to the staff. Learning experience from the SKMCH. Based on that, we designed state-of-the-art USP standard-based main pharmacy segregated compounding area. And now we are going to design the same replicate into the IPD pharmacy. We have the 2 pharmacies, satellite pharmacies. So we are going to design that area with the dedicated USP standardized, and the same replicate to the Peshawar side. And the new development of the state-of-the-art sterile area in Karachi project. Further, we assist and guide 2 other hospitals as mentioned in this presentation. So based on these learning experience, we are able to design our own HVAC system. And this is one of the drawing that modified by the pharmacy department during the execution of that. So during the commissioning, we identify major labs that are not as per the standard guidelines. So we remodel it, and as per the standards, we design and implement that. So we have the dedicated weather stations, that is a remote temperature humidity monitoring device, very interactive session, and out of range alerts will be generated through SMS to the respective team members to take action on that. Further, we based on these learning experience, we designed the building management system. This is one of the beauty of the state-of-the-art sterile area that tell us about the relative humidity, pressure differential, temperature ranges, and ISO classification, operational HVAC and exhaust system of that area. As you see in the picture, if any parameters goes out, the system will alert on the screen at this interface, which is easy to identify, and for the corrective action, we identify based on that, and corrective action has been made. These are the reference standard, USP reference standard, and the ISO and the NIOSH reference standard for that purpose. Thanks, everyone.
With that, we have reached the end of our 21st Annual Cancer Symposium. I want to thank all the speakers who put in the time and effort to make this possible. Special thanks to our chair and co-chair and everybody who came with us here today. We have a little activity which Ms. Eamon will guide you through, so please pay attention. Ladies and gentlemen, as promised, we are going to have a quick quiz session on Kahoot. The questions will be based off all the things that we have learned during this session. 2 people who win this session will be awarded with 1 week of observatorship at the Shaukat Khanum Hospital, Lahore Pharmacy Department. We will be guiding you through it all. I would like you all to pull out your phones. Those of you who have the Kahoot app,
you need to go to the Kahoot ID on the Google form, and then place the pin over there. This is the game pin, and enter with your name.
those of you who don't have the app can go to your browser and log in at kahoot.id.
MJ and Cookies are online. Amna Rafiq is online. Good. Actual Mola Jet is online. Just to add further, you need to go to the Kahoot 8 from the Google and enter the game pin and add your name. वैसे असल में इतनी खतरनाक शक्लें नहीं है आप लोगों की। To start in 1 minute. Are you ready? We are going to start in 30 seconds. Are you ready? एक ऑब्जर्वरशिप का सवाल है, जल्दी जल्दी लॉग इन करें। So we are going to start this. गुड। कुछ जबरदस्ती भी आए हैं कि नहीं? नहीं, कोई भी नहीं आया जबरदस्ती।
झूठ। नो आइडिया वाले दो है।
कुछ हैं जो जिनको आइडिया नहीं आ गए गलती से। चलें, बाकी दो हैं फन के लिए हैं। एक्सीलेंट। कुछ अभी पीछे चल रहे हैं, वो अगले सालों में आ जाए जरा। अभी आपको 20 सेकंड दिए गए थे, अब हम टाइम कम करने लगे हैं, तो चैलेंज जरा अब ज्यादा हो जाएगा। सर आप पता लगे आप इंटर्नशिप पे आ जाएं। इम्पोर्टेंट चीज ये है कि अगर एसकेएम के मेरे कोलीग हुए तो वो भी ऑब्जर्वरशिप ही करेंगे आगे। मैंने इसलिए कहा है कि अपने एसकेएम के हुए तो ऑटोमेटिकली वो नीचे आ जाएंगे।
Sir San, if we win, will auction our observer.
चलिए, ये अच्छा है कि किसी को ये ऐसा कोई बंदा नहीं मिला जिसको प्रोसीजर का ना पता हो। गुड। तैयारी कर लें, आपकी ऑब्जर्वरशिप तैयार है।
सर आपको एजेंडा भी पता है? हमें अपने लोगों को खेलने देना चाहिए।
नहीं, कोई बात नहीं।
सर डोनेट कर सकते हैं।
हाँ? साथ वाले एक दूसरे का फोन ले सकते हैं। अच्छी बात है कि आप लोगों ने प्रेजेंटेशन सुनी है। गुड। जल्दी जल्दी करना पड़ेगा। चलो मिक्स है, सैलरियां कम भी हो सकती हैं जिनकी है। ये गलती से लगता है जेम्स कॉलिंग हो गया कोई। रेगुलेटरी अफेयर्स भी हो गए हैं, ड्रग रजिस्ट्रेशन रजिस्टर्ड एंड पाकिस्तान अवेलेबल पाकिस्तान भी हो गया। जो जल्दी आंसर करेगा उसका नाम ऊपर आएगा, गलत ना हो। कुछ 3 है, ये 3 ही होंगे अब। इससे तो फायदा है हॉस्पिटल का। शहजादे हैं कोई रिटेल वाले? अब मुश्किल होता जा रहा है।
सर से फोन लो जाके। इनका फोन
ये लाहौर आ रहा है, लाहौर। वो आर खत्म हो गया ना, वो आर वाले। वैसे इंग्लिश वाले से ज्यादा निकले।
ब्लाइंड है, डेफ तो नहीं है। इसमें कुछ भी पढ़ सकती है।
5 उर्दू वाले हैं, 1 पर्शियन में चला गया है। Second last question.
इन्होंने क्वेश्चन है, आपने चीटिंग, आपने क्वेश्चन है।
Are you ready for that? Aisha Slim.
All 3 of the winners, please come on stage.
इनको ऑब्जर्वरशिप पे लेकर so
Thank you everyone for participating. Now, does anyone have any questions for our speakers regarding their presentations?
So I have a question for Sir Ghulam Mustafa. So in your presentation, you mentioned about certain risk factors, and one of those risk factors was illegible prescriptions. So now my question is, do you receive any handwritten protocols?
Yes, still we receiving handwritten protocols. Those protocols which are usually the first day of therapy planned as by physicians, and he want to give within 1 or 2 days, because CPOE orders need to be take time to build in the system. So this is the reason we still receive.
So can we have an estimate of, or whether I should say the percentages of these handwritten protocols? Because what we have seen our system, this is a major risk factor for errors, and mostly the chemotherapy errors, if they have occurred, are usually related to the handwritten protocols.
So yes, I agree with you. This is a big situation here with our system as well. So actually, we are negotiating with the physicians to make us clear before the treatment plan should be started in the clinic. So we are working on it, but you can say it's 5 to 7% written protocols. I think 3 or 4 months back, we done some statistics, how much we are receiving the paper protocols from the physician as a written regimens. So its numbers are very good, and we work on it, and we make more protocols in the system after discussing with the physician. So you can say there will be a chance for the receiving of handwritten protocols. The reason is the plan of therapy can be changed in oncology setup. For example, you can say you can start DHAP. Okay, so doctor need DCHP now because of relapse of therapy, refractory, any other conditions. So you shouldn't have to be start on. So in that case, we can consider the paper protocols, but it should be evaluated with the clinical pharmacy team, physician, and then infusion center pharmacy as well.
Okay.
So this is
that has to be applied between all the
yes, all stuff is
parties.
very, very arranged one, not a blind game.
So there was another risk factors. It was non-accredited staff. So what do you mean by that?
Actually, this is a very good question. Thing is, for example, who can prescribe denosumab?
So in our setup, like we have only oncologists can prescribe the chemotherapy.
This is the things. Denosumab can be prescribed by an ICU consultant?
No, absolutely not.
So this is the point. Ineligible staff or prescription handling. So for example, bisphosphonate, anyone can prescribe, but this should be restricted to oncologists or hematologists. And there are now many new drugs like eculizumab for PNH. Okay, so it's concerned with hematology only. If somebody is prescribing from urology, so we will not recommend him or her to prescribe it on the behalf of hematologists. So this is the eligible handling of the drug prescriptions by the physician side. So this is our point in this practice.
Thank you very much. Fair enough. Thank you.
Do we have any more questions?
Yes.
Please raise your hand. Before you start, we have like 5 minutes for this, so you might want to wrap up.
I have like 2 questions.
Sure.
Little introspective, and the other one is specific. the first question is that, are you running any kind of stewardship related to oncology or chemotherapy or at your center?
Yes, but this is already defined stewardship, working in SSMC already. So we have policy and procedure and all the workflow is there. But technically, if you say it's official, it's not. But in my previous hospital, it's definitely there is. And we are running with the stewardship with the clinical and all the stuff because it's a new setup. Actually, it's running with the My Clinic now, the USA based setup and the local setup. So there is a 2 point of conflicts to be solved between two organizations, how to workflow to be going on. So as a documentation point of view, we still working on it, but practically we are doing.
Yeah. The next question is specific. It's regarding the use of vascular endothelial growth factor inhibitors. Like we know that there are certain pain restrictions reported with them. How closely?
Which factor? Sorry.
These VEGF.
Yeah, VEGF inhibitors. Which factors?
With these drugs, like some cutaneous.
Okay. Cutaneous reaction. Yeah. Okay.
And like giving them emollients or lubricants or
yes, topical,
that, topical
and oral.
Going on, it's like a 6 weeks therapy as well, like given.
Yeah, depends upon. Yes.
How often do you come across these kind of reactions?
Yes. Yes. Okay. Frequency is not much defined yet, but we are receiving number of patients with oral VEGFR. And as I mentioned for ipilimumab, there is more black box warning for this one. And we now are creating a protocol for especially for our outpatient pharmacists, how to consult the patients for this ipilimumab therapy. And even as an oncology clinical pharmacist, we are involved in the direct patient-centered approach. But when patient is going on the window of outpatient from where he's receiving the medicines, he should aware about the protocols. So we are giving them, we run a program, scan and learn. So this one we started there in outpatient pharmacy for many drugs. So they can scan, we give them the card, they can scan and they can learn in the video and in the written form. So patient, and counseling, of course, we are doing as a outpatient staff. So in this way we are doing. And the number of patients, you can say we can 2 or 3 in a 2 or 3 months window, monthly 1 or 2 patients we are receiving with these complications. But most likely ipilimumab and panitumumab. Oral VEGFR, like others, you can say abrutinib. So we are receiving, and we set the protocol now in plan for the card, 1st grade, 2nd grade, 3rd grade, and 4th grade, how to manage it orally, topically, steroids. These are the ways we are doing on it. And we are planning for this worksheet.
Thank you very much, sir. We have just a couple of more minutes. I'd like to call Dr. Umar Akhlaq Bhutta for his ending statement. Or will you be joining?
So thank you very much, all of you, for having a wonderful session, to being in a part of this annual oncology pharmacy session, which is a subsession of the annual SKMCH Symposium, which is held by every year. And this time, this one of the, you can say after a certain break of the COVID, that we have an on-site and plus in a hybrid event that's going on. So it's just because of your participation. I would like to thank all my speakers, Mr. Ghulam Mustafa, Mr. Ehsan Alai, Mr. Sajjad, Mr. Shoaib Shamma. So all have done their, shared their experiences, and the learning thing which I've explored being in a co-chair. I was just learning from the elements that they have just shared. I've gotten a chance to learn from the oncology experience in UAB, particularly with Mr. Ghulam Mustafa, and he shared wonderful things which are a learning thing in a current practicing scenario, as Mujtaba also has raised, that accredited
personnel was the key point, which is also I have highlighted as in my question as well, but that was very well answered. Similarly, Sajad presented a very well in-depth analysis and the need of a skilled human resource in a country like Pakistan, and particularly once you talk about the subsection of a Pakistan, the country where the KPK, you can say in Balochistan and Sindh, there the health reforms are not as much as good as we have seen in Punjab region, which is slightly in advance as compared to the rest of the provinces. And talking about the health reforms in KPK, with having a certain good skilled pharmacist is something which is a very, very, you can say, an outlier within a scenario. So I believe Shaukat Khanum approach to develop a hospital like Shaukat Khanum in Lahore. They built up an accreditation process in Peshawar as well. And after the second accreditations, which is a basically joint commission enterprise-wide accreditation, which is one of the unique accreditation across the globe. The Shaukat Khanum Peshawar pharmacy is very well equipped in terms that they can develop and produce the pharmacists which are basically equivalent to the any pharmacist across the globe. So their steps moving toward the SHP International Pharmacy Practice Residency Program Year 1 is something which is appreciable, and that definitely changed the paradigm and the landscape of the healthcare reforms in the KPK, particularly as I've mentioned earlier in terms of the pharmacist role. Moving towards the Ehsan Elahi presentation, so he very well brief about the situation in Pakistan, cancer situation in Pakistan, and what are the initial quick stats, and the learning experience that he works while working in Shaukat Khanum Memorial Cancer Hospital, with having a subspecialty of oncology, hematology pharmacist. And with his vast experience, we learn that how the processes moves on and how the processes can be monitored in terms that you can say that we have certain results that basically showing us that how we started and how we are moving towards well. So basically this type of activities always helps you in terms of moving forward, planning your future things, and all those things. Particularly, I would like to highlight his work in order duplication analysis mitigation, which is basically one of the beauty of this this process learning, that how you can reduce the cost, how you can increase the safety of the patient, and how you can reduce the time of the pharmacist in terms of order and process modifications. So while talking about the oncology learning experience, you cannot end up the discussion without having the information and discussion about the preparation or the oncology preparation aseptic area. So Mr. Shamas here brief us about how the error which are associated with in terms of that drugs which are incorrectly prepared, like the concentrated electrolyte, one of the key example that basically which comes into the surface and make us as an eye opener that we should all having in a certain good standard of sterile preparation areas, including the clean rooms, how healthcare worker can be protected, how the hazardous material can be evaluated. So all those things, which includes the minimum requirement equipments, and how you can make one of the state-of-the-art sterile preparation area with a certain standard. Like if you talk about the USP 797, if you talk about USP 800, so all these things are basically can be merged up. And how the BMS system, which is one of the unique system, I'm in best of my best knowledge, I don't see this type of a system within this country. And having a such system within this country is again a learning opportunity for the rest of the institutions who are performing in the same field. And this is the beauty of this presentation. Taking as an opportunity, this was in a small session in terms of the pharmacy. We are going to make a huge, big biennial pharmacy symposium, inshallah, in Feb and March. That will be help to us to accommodate at least 500 pharmacists across the Pakistan, which having a covering of a local and overseas speakers as well. So I am thankful all the people who basically are the part of this today's session, who left due to the space constraint. We really apologize for those one, and wish you all the best for the upcoming future of the pharmacy. Thank you very much.